Good afternoon, everyone, and welcome back to the County Council session for today. We will begin with item 6, which is a public hearing and action on a resolution to approve supplemental appropriation 25-84 to the FY25 capital budget, Montgomery County Public Schools technology modernization in the amount of approximately $1.4 million. Council action is scheduled immediately following this hearing. There are no registered speakers for this hearing. The public hearing is now closed. We will now move on to the action portion of this item. Is there a motion to approve supplemental appropriation 25-84? Council Vice President Jawando moved. Council Member Balcom seconded. All those in favor, please raise your hand. And that is unanimous. Next item is item 7, and that's a public hearing and action on a resolution to approve supplemental appropriation 25-87 to the FY25 operating budget, Montgomery County Public Schools Urban Agricultural Water and Power Infrastructure Grant in the amount of $122,000. The source of funds is a state grant. Council action is scheduled immediately following this hearing. There are no registered speakers for this hearing. The public hearing is now closed. We will now move on to the action portion of this item. Is there a motion to approve supplemental appropriation 25-87? Council Vice President Jawando moved. Council Member Lukey seconded. All those in favor, please raise your hand. And that's unanimous. Great. The council will now sit as the Board of Health for our last agenda item of the day. It is our biannual update from our public health officers. And as was stated a couple of weeks ago by Dr. Bridges, who called you all our Care Bears. We welcome you from the Department of Health and Human Services. And I'm going to turn it over first to Ms. Clemens Johnson to start us off.
Good afternoon. Thank you, Council President and Council members. We will start with a presentation given by Dr. Davis and her team, and thank you so much for coming over to do our Board of Health presentation.
Thank you. Good morning, everybody. Thank you, Tara, for all your assistance. Thank you, Council. So you can go to the next slide. This is our biannual Board of Health update. Our agenda today, we are going to talk a little bit about updates from the mobile van, our regular substance use update, go into a little bit of the health of the county, our maternal health summit, and the strength of the clinical safety net. I do want to highlight that the mobile health clinic is now open for business. We had our ribbon cutting on April of 2025. It was a long time coming. Actually, we took possession of it in April. We had our ribbon cutting on May 29th. Hosted by WUMCO in Poolsville. Many of you were there to help cut the ribbon. You can go to the next slide. The clinic is in several locations. It is in Poolsville and Wheaton. It is also coordinating with the county service consolidation hubs, so the Up County Hub, Gaithersburg Cares, Twin Brook Service, Mid-County, the Mid-County Consolidation Hub at Harvest Intercontinental, the Mid-County Hub at Hughes United Methodist, the Silver Spring Consolidation Hub at Clifton Park, and the East County Service Consolidation Hub. The sites are visited once a month with the exception of Poolsville, which we currently go to 3 times a month. The services that are provided, you can go to the next slide. Services that are provided include routine and diagnostic care. So these are things like general health and wellness exams, height, weight, blood pressure checks, glucose checks, checks for A1C. We also do STI and HIV testing. We will provide flu vaccinations once flu season comes around. We offer counseling for smoking and tobacco. But the main goal is really connecting patients to a medical home. So we work with our Montgomery Care clinics as well as other clinics in the area to help connect patients to be able to have that ongoing primary care services. We also offer mental health, so we provide behavioral health screenings for anxiety, depression, PTSD, substance use disorders, as well as mental health counseling. In addition, we offer dental screenings and assessments. Currently, it's just dental screenings. We will be adding on cleanings, x-rays, extractions, fillings. It's amazing all the services that we fit into the van. We also connect folks to social services. So, for example, I was on the van, and we had a patient come in and we needed to reactivate their Medicaid, and so we helped them get connected to that. The goal of the van is really to be that connector in the community to help get people what they need at the moment and what they need for the long term. I'm excited to be able to see patients on the mobile van once a month in Poolesville, so excited to have that connection back to the community. All right, we will transition to give some substance use updates, and I will transition over to Mr. Ben Stevenson.
Good afternoon, Ben Stevenson, Acting Manager for Prevention and Harm Reduction Services. So just to give an overview of our substance use update, looking at the current slide, it kind of tells a story in regards of what we're dealing with in as far as substance use in the county. So we know that polysubstance use is still observed in all of our overdose fatalities in the county, and that fentanyl still is a driving force in a lot of our fatalities. As far as Montgomery County is concerned, there were 20 fatal overdoses in Montgomery County during the first 4 months of the 2025 calendar year. 13 of those cases involved opiates, 12 involved fentanyl, and 4 involved heroin. 2 involving prescription opioids, and then 2 involving cocaine, and then 4 involving alcohol. Even though, we're still seeing, challenges around substance use, we did see that major reduction from 2023 to 2024, which, I guess is attributed to a lot of the work that we've been doing in the county to address substance use. We go to the next slide. As far as as far as our Montgomery County, we saw decreases as far as 23%, so 6 fewer cases in fatal overdoses during 2025, 32% for fatal overdoses involving opioids, and then 25% of fatal overdoses involving fentanyl, and then 20% fatal overdoses involving alcohol. So again, in the first 4 months, fentanyl, of course, has been involved in 60% of all of our fatal overdoses versus 73% at the state level. Cocaine-related overdoses account for 35% of our total fatal cases, compared to 52% of Maryland. And then alcohol fatal cases involve 40% of our fatal cases, compared to 15% in Maryland. Looking specifically at our youth, so from FY23 to 24, looking at the 10 to 21 age group, we saw that experienced a 17% reduction in ER visits. So we think that's related to a lot of the work that's being done as far as like our SUD prevention intervention program and other community-based organizations, as far as HHS as well, also being involved in the efforts. And then from FY23-24, youth 10 to 21 experienced 25% reduction in ER visits related to opioid overdose specifically. So we know that some of those interventions have been shown to be effective. So that's 23 fewer cases. And then looking at our FY23-24, 10 to 21 experienced 12% reduction in ER visits related to alcohol. So I know opioids has been a driving force of our substance use efforts in the county. We still try to, work in partnership with like alcohol beverage services and other entities to try to address underage drinking and prevention within the county as well. We also did some recent looking at our senior population as it relates to substances. So you can look at the data. Our 55 and older population saw a 2% increase of drug poisonings, which was 10 more cases from 23 to 24. And then in 24, our white residents accounted for 58% of ER visits related to all drug poisonings, and African American residents accounted for 22%. And then during calendar year 2023 to 2025, a total of 207 ER visits due to opioid overdoses, and then 1,929 related to ER visits related to alcohol and other dependencies. So we can see that alcohol is still a challenging substance, even though it's legalized in this country, that we have to do a lot more in regards of just educating about the dangers as far as when it comes to dependency, as well as abuse and use. Next slide. This slide here just gives the county trend related to alcohol and intoxication deaths looking from 2019 to 2025, and this data is through June 2025. So we could look at the trends related to our non-Hispanic whites, which have seen decreases. So if you look at 2020 in comparison to 2024, we can see a 10 case decrease. We noticed in our African American or non-Hispanic Black community, we have seen some drastic increases from 22 to 23, and then a slight decrease in 24, and then we're seeing some decreases in 2025. And then looking at our Hispanic population, we saw a drastic increase from 2019 to 2020, some slight reductions, and then it's just kind of been holding steady. So we're looking really closely at that population in regards to what efforts that we can put in place to help to address the issue with as far as alcohol intoxication deaths. Next slide. This here also provides data around Montgomery County intoxication deaths, or intoxication ER visits. Sorry about that. So we saw that there had been one trend that we noticed from this data, that there was a major increase in yearly ER visits for alcohol for our Latino population. So we're monitoring and trying to figure out what's directly related to the trend and how we can actually address it in regards to supporting this population, in hopes to see some reductions. But in 2025, the rate, is kind of similar to in 2024. So we're kind of on pace to, unfortunately, meet 2024, but we're working to try to address and impact that community. So responses to the increased, DUIs and alcohol-related intoxications related to Hispanic males. So we're looking specifically at, putting more information around printable materials, in Spanish, radio interviews, as far as Facebook and social media avenues and things like that. Doing more outreach, so using community health workers to do outreach in different spaces. Our mobile crisis outreach team to engage with persons dealing with alcohol use disorder, as well as utilizing our street and community outreach through Identity and other partners as well. Also looking to implement psychoeducation initiatives, looking to assess, the interests of like multilingual classes. So even though we noticed that our Latino males are the primary driving force around these numbers, we want to engage with their families and family members to figure out ways to support the family, as also a catch point to provide referral sources and resources and things like that. And then also connecting to treatment directly around substance use or alcohol use disorder. So working with our MCOT teams, as well as our STEER team, which also indicates that a lot of their referrals that comes into STEER are alcohol related versus opioid related, which initially, started the inception of that program. And then also looking at assessments and evaluation. So working with MCPD to analyze and figure out alternatives to, incarceration, so that we can connect them with services and programs as well. And then just assessing the ongoing, impact of these services and programs that we're looking to provide. Next slide. And for our use of opioid abatement funds, we of course have reestablished that youth residential program, which has been successfully utilized thus far. Looking specifically at some of the intervention goals around our emergency procurement around our substance use prevention intervention program. So it was mainly to build trust and relationships with youth and their families, to connect them with services and supports related to fentanyl and other drugs, connect opioid affected youth and their families to resources and services. And then when they're ready, because of course a young person has to be ready to accept and receive treatment, connect them with the appropriate level of care when appropriate. So from February 2024 to February 2025, we've served 581 unduplicated youth and their families, and 828 duplicated youth reached or contacted through providing awareness and information and education. 40 families of we connected 40 families of opioid affected youth with resources, 389 unique referrals to supportive care, which averaged about 10 referral per contact or per client. And then also 340 referrals were successfully completed, which was a 87% completion rate for utilizing referrals. And then as far as connected to opioid dependency, we had 30 youth who were experiencing opioid use disorder. 13 of those youth successfully completed treatment, and 2 clients attended treatment more than once. So we know that when it comes to opioid use disorder or substance use disorder in general, that it's a roller coaster that sometimes a young person may have to go through treatment multiple times to potentially be successful. And then the inception of our contract with Identity to implement the SUD prevention intervention program took place on March the 3rd. To date, they've served 31 youth, average age between 10 to 21. 6 of those youth are in treatment, 1 in outpatient, 3 are currently in medication-assisted treatment, 6 completed outpatient or inpatient treatment, and 2 are receiving ongoing peer recovery support as well. Also, and I'm trying my best to get through this and not take up too much time, but also we're expanding the Office of Prevention and Harm Reduction, so potentially hiring the new harm reduction manager as well as a new prevention manager, and implementing public awareness campaigns. So we've been doing a lot of work in regards to working with our health initiatives to develop culturally competent campaigns to meet the needs of various populations. So working with the African American Initiative, Latino Health Initiative, and Asian American initiatives. And also we implemented one round of community grants. So the grantees for the first round was Arise and Flourish, Dante's Boxing and Wellness Foundation, and RecMo United. We just completed review of the second round of grantees, so those should be announced shortly. And then we're also looking to implement a third grant cycle in FY26 to implement an early prevention program for upper elementary school and early middle school age. And then we actually just completed our first round of BOTVIN training for trainers within Montgomery County. So we just trained 11 new people to be able to implement BOTVIN life skills at the middle school level. And then in the fall, we're looking to train more people to actually implement the high school curriculum as well, because we feel like that program would be helpful to be universal across the county. And then also as far as harm reduction vending machines, because I know that question may come up, we're working through the procurement process to get to that place. But in the meantime, we're going to procure Narcan kiosks. So they can hold Narcan, fentanyl test strips, and things like that, and also literature that could connect people to additional resources and things like that. And I think that might be my last slide.
I think one more.
Oh, okay. I'm sorry. Next slide. Okay. Also for prevention and harm reduction, we've of course expanded our prevention efforts, trying to build upon the work that has been done previously. So significantly working to increase Narcan and Narcan access. So working with different entities to find different ways to reach people. So in FY24, we trained 4,879 individuals on Narcan. So that was a 67% increase from FY22. We distributed 9,762 doses of Narcan, which was an 81% increase as well. As far as our evidence-based curriculums and presentations, we've reached 6,476 students in FY24 and the first quarter of FY25. We've had an increase of membership for our Be the One Youth Ambassadors, so you might have been fortunate enough to hear a few of them this morning, where they've done a lot of work in regards to educating their peers around the dangers of substance use, around the importance of mental wellness, as well as the importance of just overall wellness. So this year we were fortunate enough to have about 60 youth involved in that program, representing 13 high schools within the county, one private school, and we also had one middle school student that was very, very impactful during this work. And that was an increase from the 37 youth we had involved in FY24. Our STEER program has served 592 county clients for high-risk overdose in FY24. 82% completed screenings, 52% received a referral to treatment, and 57% of those received referred engaged in treatment after the referral. Also, as far as our crisis stabilization room is concerned, it was opened in September 2023. This program admitted 409 individuals in 2024, ensuring, of course, timely intervention and connection to recovery supports for the 70% of these individuals that presented with substance use concerns. And then we also doubled recovery support for incarcerated individuals as well. So as incarcerated individuals face a 40 to 129 times higher risk of overdose upon release, the jail medication assisted treatment program served the double number of clients from 2023 and provided Narcan training to those with opioid use disorder, ensuring every individual had access to Narcan kits upon release, which we feel that the time upon release is very important because it's a very high risk time in regards to a person potentially going back and using the same amount that they used when they went in, and unfortunately they could run the risk of overdose. So now I will yield, and I think that is my time.
All right, thanks, Ben. And we want to close out this section by talking about an emerging issue, which is Kratom. So for folks that are not familiar, Kratom is actually a tropical tree native to Southeast Asia, and it has been used and is used in traditional practices for centuries. It has been used as a mild pain reliever and a stimulant, and now millions of Americans are also using it, claiming that it eases symptoms of chronic pain, addiction, and helps manage stress. What we know is that in low doses, Kratom acts like a stimulant, but in high doses, it acts like a sedative or an opioid. Sometimes it is referred to as gas station heroin. You can buy it in gas stations, usually at the front of the store, and there are lots of well-documented risks that come along with Kratom. So it is addictive. It can cause dependence. If you have seen anybody talk about their Kratom use, they have explained it as actually being harder to come off of than some opioids. Users will experience physical withdrawals when they try to stop using it, and long-term or heavy use can actually result in liver damage, seizures, and psychosis. So even though it is readily available, it is not without its own risks. And when we look at the various legal statuses that are currently happening across the country, Kratom is getting a lot of attention. It is not FDA approved, and the FDA has actually issued safety warnings about its use. It is banned in some states: Alabama, Arkansas, Indiana, Rhode Island, Wisconsin, and Vermont. But many other states have various state regulations that include things ranging from age restrictions. So the Maryland legislature actually just passed legislation banning the sale of Kratom for anybody under the age of 21. There's also regulations around accurate labeling about the risks, the impacts. You can't use synthetics, things of that nature. There's also, state restrictions that specifically speak to marketing to children, which is included in Maryland, the strength, labeling, testing, permitting, and taxation as well. So this is an issue that we are monitoring within public health services. Right now, we've been following the legislation at the state level, and we'll continue to keep you all updated as we hear more. Thank you.
Thank you. We will transition now to talk a little bit about the health of the county. I don't think that we had previously shared the 2025 county health rankings, so excited to share that Montgomery County again is one of the healthiest in the state, as well as one of the healthiest in the country. Unfortunately, this will likely be the last year of the county health rankings. Robert Wood Johnson has decided to divert those funds. While Montgomery County has better than average overall health and well-being, there are still several areas of improvement. We're going to talk about that a little bit later. I am proud to serve as health officer for the largest, most diverse, and healthiest county in Maryland. The healthy rankings look at health factors and health outcomes. Health factors are both personal, like smoking and wearing seatbelts, as well as societal. like access to clean water. It's the interplay between these that drive the positive health outcomes. And so when we look at Montgomery County on what we are doing well, and on the next slide, it shows several of the things that we do really well on that drive our high health rankings. So we live longer. We have lower rates of premature death. Premature death is defined as a death that occurs at age less than 75 years. And they calculate potential life lost before age 75 per 100,000. Montgomery County has 4,800 years of life lost versus 8,100 in Maryland and 8,400 in the United States. So we have 41% better than Maryland and 43% better than the United States. My family can attest, many of you know that we in Montgomery County live really long lives. We have a strong health infrastructure. Much of that comes from the investments that we have made for things like Montgomery Cares and dental, which gives access to care for people that may not otherwise have it. So we have more primary care physicians, we have more dentists. Our preventable hospital stays are lower. That's looking specifically at the Medicare population. But because of those investments that we have made that creates access for people who may not otherwise have it, that speaks to that strong health infrastructure, which is one of the things that we do really well. There's also physical environment. So clean air, clean water, access to parks. Montgomery County ranks really well in that everybody, 100%, have access to free recreation. That's one of the things that actually is tracked in the report. We have invested in our rec centers that everybody can have access to those for free, but we also have access to parks and green space. And so one of the things that is marked in the report is what's the distance to be able to get to a green space. And so being able to get to green space within a couple of miles. And the report says that everybody in Montgomery County has access to that. Also better socioeconomic factors. So we have a lower percentage of children in poverty, but we also invest in children and folks who are in poverty. So investments in school system, access to childcare, access to vaccinations and reading programs, all of those things at early levels and all ages are part of the things that drive our good health outcomes. And then the last, we do significantly better in terms of having fewer injuries. So in terms of injury deaths, we are 50% better than Maryland, 44% better than the US, and that speaks to lower rates of gun violence and suicides, which also contribute to lower injury deaths. So a lot of the work that we do around knowledge around decreasing access to guns really does translate into what's going well. And yet, we know that we are doing a lot of things well. We also have ongoing disparities. We continue to see persistent disparities in health outcomes across all racial and ethnic groups. And rather than listing every data point, the key takeaway is that every community faces its own set of challenges. There is no single group that is untouched. And that's why our approach must be both data-driven and community-centered. Montgomery County is one of the most diverse counties in the nation. No racial or ethnic group holds a majority. Over the past 30 years, we've experienced major demographic shifts, and yet we continue to rank among the healthiest counties in the country. That is not by accident. It is because we invest in our communities, all of our communities. This information that on the screen has been shared with our minority health initiatives and programs who are using it to guide their strategic priorities and tailor outreach efforts. In alignment with this, we are also launching a new initiative focused on the state of Black health in the county as part of DHHS's broader strategic plan. And the initiative will help us dig deeper into the underlying causes and guide targeted action. Both the Latino Health Initiative and Asian American Health Initiative have recently launched on state of Latino health and state of Asian health, but there has not been a comprehensive look at the state of Black health for a number of years. What's also important to name here is that these disparities are not simply the result of individual choices. So back at the beginning when I was talking about the social drivers and behavioral factors, some of those are individual and some of those are societal. We need to recognize that disparities come because of structural and society inequities, things like access to care, quality education, affordable housing, and safe neighborhoods. As your health officer, it is my goal to eliminate these disparities, not just narrow them. And I believe that we can do that here in Montgomery County, the largest, healthiest, and most diverse county in Maryland. Doing so means rethinking how we define health and ensuring that health equity is embedded in all policies. It means making sure that as we invest in the things that keep us well, we are intentionally reaching the communities that need it most. And with that, we will transition to Mr. Sean O'Donnell, Deputy Health Officer, to give the respiratory disease update.
Thank you, Dr. Davis. So this is just a little bit of an overview of the past year and what we've seen with respiratory disease. Over this past year, we've really seen a shift from COVID causing a lot of the respiratory disease to influenza being the biggest cause of serious illness, of hospitalizations. On the right, the black line is all respiratory disease, and you can see a lot of that is being driven by the blue line, which is influenza. So influenza hospitalizations in patients are largely our seniors or immunocompromised, and so that has not changed. Respiratory disease, any type of respiratory disease affects those populations the most. But you can see this year, as far as inpatients go, COVID-19 is really a lower cause. It's still adding to the overall disease burden, however. When we look at outpatient visits, it's actually interesting in a very significant portion of our outpatient visits were that population under 4 years old and 5 to 17. Of course, when a parent has a very, very young child, usually under 1 year old, any significant illness, they'll go to the ER or they'll go to see their doctor to rule out anything more serious. So that's not too unusual. But when you look at the outpatient visits, it's a lot of our younger folks. The serious illness is a lot of our older folks. But we just wanted to highlight there has been a bit of a change this past year in that disease burden in respiratory disease. It emphasizes the guidance that we continue to share and much of the country shares about sort of universal precautions for respiratory disease. Stay home if you have those symptoms. Isolate yourself from other individuals until you start feeling better. So let me go to the next slide. Thanks. As of, in fact, this past week, our infectious respiratory disease levels remain very, very low. We're just starting to see a little bit of an uptick of COVID, which the last few years we've seen a summer wave. So far it is very, very low, but we're starting to see a few cases in our long-term care facilities, in our shelters. We continue to do lots of surveillance. There's lots of tools we have locally available that we'll continue to use. There's tools at the state and still federal level to track these. So we'll continue to keep you all informed. I believe you all receive every other week we push out an update on respiratory disease just to let you know we're still looking at it. So one thing that's happened over the last month or so, FDA has come on and provided direction to the COVID-19 vaccine manufacturers. They've targeted an updated vaccine that will look at the JN.1 variant. So that means there will be, as there has been in previous years, a new vaccine type for COVID this fall. It remains to be seen what the guidance will be from federal partners on who should get it. As I think most people know, if they've been following the news, the advisory committee that works for the CDC and usually provides recommendations on who should get vaccine and how they should take it that group has been reconstituted by the Secretary of HHS. They are scheduled to meet over the next few days, and we'll see what their recommendations are. There are other groups, the National Academies of Physicians and Pharmacists, and many of the other academic institutions are looking to form guidance as well in the event that the guidance does not appear to follow the science. We will continue locally to provide you all with an updated view of what the risks are from these diseases and what the appropriate recommendations are.
All right, thank you. So also just wanted to highlight Advancing Maternal Health in Montgomery County. We hosted a convening back in March and a follow-up to review data just a few weeks ago. While Montgomery County averages better maternal and infant health outcomes in the state, we also experience racial and ethnic disparities in birth outcomes. And you can go to the next slide. The convening was really the beginning of having a concerted effort to look at what's going well, where are the challenges. We brought together 69 participants. These included healthcare providers, researchers, policymakers, advocates, and families to really explore the issues. So discussions centered around critical issues such as access to quality care, the impact of systemic racism, socioeconomic constraints, and the importance of culturally competent healthcare practices. You can go to the next slide. Some of the goals were, one, foster partnerships. What we hear from a lot, and not just in this space, is there are a lot of people doing a lot of things and aren't talking to each other. And so creating that space to for folks to make connections and create some of those collaborations even outside of the health department for folks to work together. Deepening illuminating challenges, so deepening the understanding of the systemic issues, of the racial disparities, where there are challenges in access to care. We also had the opportunity to hear from our hospital partners and some of the work that is going well. I was really encouraged to hear all of the efforts that our hospitals have made and are making to address maternal health. They all see it as a priority and have all instituted measures not just to address maternal health overall, but specifically to address the disparity that we see in outcomes. Working to identify and prioritize solutions and also to drive community engagement. We had a follow-up meeting hosted by our Fetal and Infant Mortality Review Board a couple weeks ago to share the outcomes of the maternal health report, the maternal and infant health report, as well as the OLO report that was recently released on maternal health disparities. That was really a deep dive into the data. The next steps, we continue to prioritize investments in maternal health. You have heard before about many of the maternal health programs that we have, especially Babies Born Healthy, the SMILE program with African American Health Program, the Montgomery Perinatal Partnership. We are looking to establish a steering committee to lead the development of recommendations for the county. We are working with our partners to seek grants to help fund that because there's not really money at the state and county level. So we are looking to find additional resources for that, with the goal being to come back to this body in a year or two with recommendations on how we can improve and eliminate the maternal health disparity.
And as Dr. Davis mentioned, we in Montgomery County were very fortunate to have a large maternal and child health program within our public health services portfolio. And most of the services that are provided in our maternal and child health programs are home visitation programs. So our team of community health nurses and community health workers provide home visitation services to about 2,000 pregnant women each year. In addition to home visiting, and actually I should just note on that, when we look at the individual numbers for fiscal year 24, our Babies Born Healthy program saw 180 moms. Montgomery Perinatal Program saw 1,772 moms. Infants at Risk was 130. Child-led poisoning and asthma saw 98. And our Perinatal Administrative Care Coordination Unit, which screens all of the new Medicaid enrollees, triaged 2,488 individuals and connected them to services. This also includes our fetal infant mortality review team and child fatality review teams, which have the important yet hard job of doing an in-depth case review of each infant and child mortality that happens in the county to see where were there systematic shortfalls, where were there social determinants of health needs, what are the trends, where do we need to do broader education, where do we need to funnel quality improvement recommendations up to the hospitals and other community providers. Next slide. All right, and closing us out, the strength of the clinical safety net. So we did want to take a moment and talk a little bit about our current safety net. We'll start with Montgomery Cares. So in fiscal year 25, Montgomery Cares, which is our program for uninsured adults, has served 22,729 unique patients with over 63,000 encounters as of April 30th. This includes primary care, behavioral health, and specialty care. To date, Montgomery Cares has reached 88% of the budgeted number of encounters for FY25 and is expected to exceed 76,000 encounters by the end of this month. We had originally budgeted for those 72,000 encounters, and we are continually grateful and appreciative of council for the supplementals that you guys approved to make sure that we could continue to provide services through the rest of this fiscal year. Montgomery Cares has seen a 10% increase in unduplicated patients and a 13% increase in encounters compared to April of FY24. About 8% of the encounters are completed through telehealth, which is great that we are having that option, especially in these times where folks are understandably afraid to go get care. We currently have 11 health centers across the county that provide care. New patient appointment wait times currently average 12 days, which I know it takes me longer than 12 days to get an appointment with my primary care doc, so that's pretty good. The longest wait times are for the new patient appointments, which can be 8 to 12 weeks. The established patient appointment wait times is about 5 days, which is pretty good. The longest wait time for an established patient appointment was 15 days. The majority of our clinics continue to indicate that to the county that they have increased capacity to serve more patients, and all besides Care for Your Health are currently accepting new patients. Next slide. Our Care for Kids program provides health care for uninsured children and youth. So in FY25, Care for Kids has provided about 6,300 unique children with primary specialty dental and behavioral health services through 7,400 encounters as of the end of April. When we compare this time period to FY24, we did not see a change in the Care for Kids unduplicated patients that were receiving services, but we did see a 9% decrease in encounters. So the number of kids didn't decrease, but they're not going to get care as much. Our Care for Kids providers include Kaiser, our school-based health and wellness centers, as well as community providers. The priority for Care for Kids is to place those medically fragile and complex patients with Kaiser because they get access to their broader network. An additional priority is to increase and maximize all of the available slots within our school-based health and wellness centers to help defray costs to the community partners. So really leveraging those school-based health and wellness centers. And we could certainly use council's advocacy to the community about this program, telling your constituents that it is available and encourage our uninsured kiddos to take advantage of it. It is safe for residents regardless of their immigration status, and want to get them connected to care. Next slide. The most recent projected Care for Kids enrollment for unduplicated participants is about 10,000. The original 10,181, the original projection was a 12,000, and that was based on the trends from the previous years. This does represent a slight decline from FY24. The program had experienced a steady growth in unduplicated participants, which justified that higher projection in FY25. However, in September of 24, PCC reported uncertainty around the year-to-end projections due to the closure of that point of entry program at Rocking Horse, and its potential impact on the Care for Kids population. So this, even as we still are projecting to serve 12,000 kids, PCC also noted that the current political climate is also having an impact here as well. Next slide. So when we look at our safety net overall for Montgomery Cares, while there is universal and very valid fear around immigration enforcement, it's felt by our patients, it's felt by our staff across the safety net. Changes in utilization have honestly been mixed. So some health centers have reported a decrease since the new administration was established. Others have reported consistent or higher utilization. It really just depends by health center. At this time, it might still be too early to tell what the total impact is. When we look at our top specialty care services, because we do provide some specialty care through our Project Access, physical therapy, hematology, oncology, orthopedic surgery, radiology, and general surgery are our top services that are utilized. When we look at our top specialty care area needs as of the end of March by Primary Care Coalition, that is cardiology, nephrology, neurology, ophthalmology, dermatology, and oncology. So the implementation of the Islamic Center of Maryland being added to the network in FY26 will support areas in primary care, diagnostic labs, diagnostic radiology, gynecology care, pharmacy, case management, and care coordination. When we look at Care for Kids, we're going to continue to watch the enrollment in the program and the enrollment in the counters. While we have, hypotheses as to why folks are not seeking care maybe as they were the previous year, but we haven't received any specific feedback. There is a general concern from some of our Care for Kids patients about losing access to the program, that the program is going to go away. And we have reassured them that, this is a commitment of the county. DHHS and PCC are in the process of offering medication-assisted treatment training to the Care for Kids provider community to support our overall substance use efforts. And throughout FY25, when we look at our gaps, there continue to be gaps in dental specialty care, particularly the need for complex surgery, oral surgery cases. The kids that Dr. Boyce is seeing in her clinic just have really high acuity needs. And so PCC and the Primary Care Coalition have recently executed a partnership with a local oral surgeon to help meet this need. Next slide. And this is just a snapshot of Medicaid in Montgomery County, which Dr. Davis is going to briefly chat about in just a moment, but Medicaid's been hot and heavy in the news along with everything else, it seems like. So when we look at Medicaid within the county, proposed changes to Medicaid, they would mostly impact expansion adults, so folks who got Medicaid access to Medicaid through our Medicaid expansion in the state of Maryland. There's about 46,000 individuals that fall into that bucket. It's about a third or a half that would lose coverage due to the burdensome requirements. So this every 6 month validation or any other administrative requirements that are put in related to re-verifying your enrollment. There is the potential that 15 to 20,000 uninsured residents of Montgomery County that would then be eligible for Montgomery Cares if they lost access to their Medicaid. Now we'll see where all of this kind of pans out. I think it is still too early to tell for lots of things, especially until the big bill is passed, whatever it looks like. And so we are monitoring very closely what that is looking like because as you are probably aware, Montgomery Cares would have limited capacity to absorb all of those individuals. Dr. Davis?
All right, so you can go to the next slide. Just a few last general updates. I do want to make a comment about measles. I'm sure you are all aware of the cases that have happened around the country. It seems like we have hit the peak. They are starting to decrease. In Montgomery County and Maryland, we have had a few sporadic cases. They have all been associated with international travel. Thus far, all of the investigations that we have been a part of, they have not spread. They have been isolated to the index case. That is in large part because of the high vaccination rates that we have in the county. We know that the MMR vaccine is safe and effective. We work really closely with MCPS on ensuring access to vaccines. The co-location of our vaccine clinic with their welcome center for new students is really helpful. Students come, if they are international arrivals, they get registered for classes. If they're missing vaccines, they can literally go right next door and get vaccinated. We have also worked with our shelters, the Newcomers Now Lighthouse program, in helping to get MMR vaccines for new arrivals as well that come to make sure that if they did not get vaccinated in their home country, that they can get access to that with us. We remain vigilant, and our contact tracing nurses remain busy. We just had another case this weekend that come up. We work with DC, we work with Prince George's County whenever they come. We track everybody down. And we are also happy to talk to any community groups about vaccinating. What I found as a practicing physician, people have a lot of misconceptions, concerns, fears about vaccines, and oftentimes I find when you have an open, honest conversation with somebody about their fears and concerns, as opposed to trying to belittle them or say that they don't understand, having a conversation that seeks to have understanding and gives people facts goes a long way to getting them vaccinated. And so happy to have those types of conversations with smaller community groups if that's helpful. Vaccines just in general. I too am concerned with the recent actions that removed and replaced all of the members of ACIP, the Advisory Committee on Immunization Practices. That new committee meets starting tomorrow for the rest of the week. We will stay tuned on what that group says. Those recommendations still need to be approved by the CDC. We are also monitoring what other healthcare professional organizations such as the American Academy of Pediatrics, the American Academy of Family Physicians, ACOG, and others are saying around those vaccinations. And so there is a concerted effort amongst the medical community to review those recommendations and to come up, adopt what needs to be adopted. So we stay vigilant, we continue to watch, and we will work on educating the public on what the new recommendations are once they are finalized. And lastly, I just want to talk a little bit about federal actions. We also know that there's a lot of uncertainty about federal actions. We thank the council for filling the hole in HIV care, and we know that there will be more cuts, and we don't always know where those cuts will be and where and when they are coming or why. We are working with MDH on a prioritization exercise. Their priorities, which in many ways align with ours, are operational excellence, improving health over the lifespan, and strengthening health equity. And so we know that when we're ready, when cuts potentially have to be made, making sure that we are prioritizing those things. As Dr. Ashford mentioned, we remain concerned about the proposed changes to the Medicaid program. We know that Medicaid is a lifeline to many in our community. Montgomery County has been very progressive. Montgomery County and the state have been very progressive, and we see that in our health outcomes because we have invested in coverage for expansion adults that contributes to why we have such good health outcomes. So we know that it is a lifeline, promotes prevention, and enables folks to be productive members of society. And with that, I will turn it back over to the chair for any questions.
Turn on my mic. Thank you so much, Dr. Davis. We are incredibly fortunate to have you as our health officer here in Montgomery County and to have the whole team. That was a terrific update. We appreciate you all being here. I'm going to actually turn over to the Chair of Health and Human Services to kick us off on comments and questions.
Thank you very much, Madam President, and appreciated your words this morning, Dr. Davis and team, talking about Behavioral Health Awareness Month. So you touched on so much of what I am thinking and what we're all thinking, and the anxiousness and the anxiety that we're all sort of experiencing right now, and the many unknowns. But could you just talk a little bit more specifically, maybe about some of the regional efforts that are underway because of the potential reductions that are looming, particularly within the budget resolution? I know that there is a tremendous cross-section of work that happens among jurisdictions, and that you all have been convening and doing your best to prepare. But could you talk a little bit more about that? Because while obviously we're going to do everything we can within Montgomery County through the existing infrastructure and Montgomery Cares, but we're not going to be able to serve everybody, and not all jurisdictions have similar constructs. So just wanted to give you the opportunity to talk about what the regional effort looks like.
Sure, thank you for that. So certainly, as part of the state health officers meet regularly and have been planning together on budget implications from that. But we also work extensively with the COG and the Health Officers Committee, which I co-chair along with the health officer from Prince George's County. We are actually meeting collectively later this week and so COG, for those who don't know, includes Frederick, Montgomery County, Prince George's County, Charles County from Maryland, Washington, D.C., and then our Northern Virginia colleagues as well. And so we are collectively strategizing around how, homeless folks don't know borders. And so changes that happen in any one jurisdiction affect us all. And so we are collectively strategizing on that, actually meeting later this week with some of the big healthcare funders to think about if funding gets cut in our jurisdictions, how can we work collectively both with government money but also with our philanthropic partners to help fill some of those holes.
Thank you. And, I'll just say it up front, that we met more frequently during COVID because we had to, and there's a chance moving forward that this body may have to convene more frequently than we normally do based on what's going to be happening at the federal level. And obviously this body, as always, stands ready to support your incredibly important efforts. The other couple of questions that I had, and it's heartening to see that the numbers, while decreasing, are not lower. But what efforts are we taking underway to make sure that we're proactively letting our residents know about the opportunities available to them? I appreciate you wanting to partner with the council and sharing that in your presentation and willingness to make one-on-one presentations, but how are we leveraging our minority health programs and initiative and nonprofit organizations and faith-based organizations? I know that work is going on, but just wanted to give you an opportunity to uplift some of that work as well.
Sure. So we work very closely with our minority health initiatives and programs, and they have all been gearing up for the fall in terms of campaigns around vaccination. There have been some challenges in terms of funding that was supposed to go to some of those proposals that has been cut, but we continue to work closely with them. We know that what we learned from COVID is that relying on our trusted messengers, and sometimes those trusted messengers don't have a government logo badge on them, and so really working with the community. Also using our food consolidation hubs as another place, now that the mobile van is in those areas, that's another place where we can, one, help to vaccinate, but also use to educate. We don't know if we'll be able to afford to provide COVID vaccination. We expect that we'll be able to provide flu vaccination, but at least being able to connect folks with those resources where they're available.
Thank you, Dr. Davis. And there's so many troubling articles that we're all reading every day. I've read an article in the Washington Post today that there is a parallel infrastructure being considered in the event that things get even worse with vaccinations, and that's going to cause, with the best of intentions, probably even more confusion that's out there. So there's not a lot you can say right now that's going to make us feel any better beyond what you've already stated. But we're just going to have to obviously continue to be vigilant and be as proactive as possible. But some of what we rely on for information, that infrastructure is decaying. So we're going to have to look at creative methods within our own county that we can control. And obviously there won't be very many easy solutions there. That's it for now. Thank you very much, Dr. Davis. I appreciate your leadership. Look forward to the continued collaboration. I yield back to you, Madam President.
Thank you. Councilmember Natalie Fengazalis.
Thank you so much, Madam President. First of all, thank you so much to all of you for all your work. Very quickly, I appreciate the presentation on the response to increased DUI in Hispanic males. It was actually a few months ago where the Public Safety Committee had a presentation on DUIs, and that's how I learned about this issue. Then I had a meeting with the police department, and they showed me all the data. 50% of the DUIs come from Latinos. 50. And I immediately reached out to partners, including your team, as you all know, I'm doing my own outreach on this area with my little flyer that has been a hit, by the way, which I'll share with all of you. It's bilingual, obviously, but something that I didn't see in the presentation on this slide that you have with outreach and engagement and connection to treatment recovery, all that. It's very important to do intentional outreach in restaurants and in laundromats and in faith institutions, because sometimes, per my own research, is Latinos who are single, people who feel lonely, who are very depressed. They are the target. And I was talking to Jose Ortiz, who's sitting over there from my team, who's my right hand on this issue. And we're trying to figure it out how we can engage not just the restaurant owners, but also the waitresses, people who work serving, not a bartender. And for that, I'm going to be reaching out to ABS, and perhaps you should be with me, and deal with that, and a lot of education, and also creating more of a sense of social responsibility with certain establishments, to understand that if you see somebody who's who's having 3-4 drinks and that person is already drunk, you have a social responsibility to stop and call an Uber or whatever taxi. I know the lawyer just told me, don't say Uber, say ride sharing. Fine, ride sharing services. But I think we need to be more intentional on that, be very specific. And I wanted to say that on the record. And I thank you. I yield back.
Thank you. I just want to respond. So, Councilmember Fanny Gonzalez, I want to thank you for raising the issue. So one of the things, I think those are great recommendations, and we will certainly send our teams into those areas. One of the challenges that we face is the delay of data. So, and you're looking in these presentations, we don't get death data until, it's not certified until a year later often. And our epidemiology team can pull ER data, but there's often a delay. And so we at the health department, is very difficult for us to hear about the smaller cases and things that are happening in smaller neighborhoods, especially if they don't die or don't end up in the emergency room. And so until you let us know about things like that, we often don't hear about them. So continue to bring them forward. If we don't hear about it, it's because it hasn't bubbled up. You know, the 1 or 2 cases often don't make it to the top of the list. And so we appreciate that communication and outreach.
And I hear them from the police department, so you understand. This is why they are a partner, and we should always be working with them. So.
Just to kind of add to what you were saying, we're also actually doing some coordination with ABS. So I've been in contact with their community outreach person around providing tips training, which is training for bars and restaurants for servers to make sure that they're carding individuals, but also monitoring individuals to make sure that they don't overserve a person. And then also doing some partnership in other spaces under the leadership of ACAO Mora. To connect with other entities, just like you were indicating, like bars, not just bars and restaurants, but laundromats and other, locations, just to try to, education. I think the challenge with alcohol is that since it's legal, sometimes people may not view it as an issue, and so I think getting to those community norms and dealing with those perceptions of harm is our way of those risk factors that we probably need to attack to try to change the trajectory of what's going on.
Thank you. Councilmember Balcom. Thank you. So it's always, I'm always so impressed by the team and everything that we're doing in Montgomery County. But when we see it all together for these updates, it's just outstanding, just how many areas you're covering and how Montgomery County really does stand out. And particularly looking at the obstacles and trying to address where we're not doing well and addressing those. So I really appreciate that. I also appreciate Councilmember Albornoz for bringing up the impact of the federal government and changes in Montgomery County. And we hear anecdotally what's going on every single day. But you all are on the front lines in terms of access to health care, both medical and mental health care. And if our residents don't feel safe, we need to know about that, and we need to brainstorm how we can make sure that our residents don't stop seeking care. And so I appreciate that we have this relationship, and that you'll let us know if there's anything that we can do to help you with that piece. And then, of course, the mobile health clinic, I'm just so overwhelmed with joy about the opening of that. It was such a joyous occasion, and I really appreciate the whole department's look at rural health. It was something that, when I first came in, it was new to me. I wasn't aware, and HHS has been just such a strong partner in making sure that all residents are served. So I appreciate that. My question is on the Kratom drug or substance that's happening. This is really great timing in that on Friday we had a community conversation, and it came up. One of my constituents
brought the issue forward, and it was very fortunate in that I had the commander, Satinsky, was with us, as well as one of our chiefs from the volunteer fire department, and we had a really good community conversation about this dilemma, and both from the EMT perspective and the police perspective, they're seeing it. And we had a gentleman from the high school booster club, they're seeing it in the high schools. And so we started looking into it, and then this came across our desk, so it was perfect timing. The question I have is about enforcement and regulation. So we understand that there's been state legislation, the regulations are coming. When and where do you see enforcement taking place to make sure that these substances aren't sold to minors? Also, the advertisement. I mean, if you look at the packaging, it looks like they're candy, or they really are marketed towards teens. So, what are your thoughts on enforcement?
I mean, I think that ultimately comes down to what the legislation, and is it at the state level, is it at the local level? I mean, in the state legislation, they can't provide it to an individual younger than 21. I think one of the outstanding questions is from the local health department perspective. You know, we get funding from the state for tobacco enforcement and things of that nature. So I am not clear at this point as far as if that would be rolled into our underage purchaser program. If it is, it probably will not come with additional funding, which is always the challenge, right? Because our tobacco enforcement is a little bit of a struggle right now. But you know, if the county decided that it wanted to do some additional legislation to either ban or enhance some of the restrictions, then I would just say that to also in that consider what the enforcement resource needs of that would look like. I know that the state, the Senate, there was a desire from the legislature to get more scientific evidence. I think the evidence is starting to bubble up now in mass quantity in terms of the negative impacts of Kratom. And they didn't take off the table banning it within the state and potentially adding Maryland, but they wanted to make sure that they had evidence to support that decision if they did.
Great, thank you. Yes, so we'll be monitoring that as well in terms of what that enforcement looks like. But the police are, you know, their hands are tied because it's not an illegal substance and they can't test for it. But they're seeing the impact of it as well as the EMTs. So I really appreciate you having it on your radar. So thank you.
Okay, Council Vice President Joando.
Thank you very much. And I also want to double tap Councilmember Balcom's point just about how amazing it is when you all do this and how much you're doing every day. So to you and your whole team, thank you so much. I just have a couple of questions, and I'll try to be quick because I know other people have questions. On the substance use, excited about the mobile clinic. Awesome. Can't wait to I haven't been in it yet, so I'm excited to get in it. We've been talking about it since I got on the council, so I'm really excited to get in it. The reductions that we're seeing in substance use related deaths, which are great, is that more related to, and if we go to that chart, but I thought it looks like we're on pace for another 50% reduction maybe this year. Is it the Narcan use? Is it less cases, or is it just less deaths, or both?
I would probably say it's a combination of both. We have definitely saturated the community with naloxone in a lot of different spaces. In addition to, HHS's efforts to distribute naloxone, we've helped about 9 different organizations become overdose response programs where they can train and dispense Narcan as well. And then also working with our fire and rescue partners to make sure that they have kits at all of the fire stations to distribute when anyone walks in there. And then also working with the libraries to find, opportunities to distribute at the library and Montgomery College and different spaces. So I think it's a combination of those efforts, but also just a combination of increased awareness around around the dangers as well, because I think initially we were in a place where a lot of people were unaware of what opioids were because they weren't directly impacted. And I think our efforts around community awareness, the increase of access to treatment and things like that, in addition to, the harm reduction efforts that we're putting in place, have been helpful.
So there are less cases in addition, as well as
Yeah,
less deaths.
so
it's not just that they're
yeah.
not leading to death as much.
Right.
There are
So-
the cases are going down.
Right.
too.
So we've seen reductions in not only our fatals, but also our non-fatal overdoses. So I think,
The other question I wanted was a data question, and I have one more. The disparities data chart on 18 is through 2021. I know you talked about this about lagging data, but that's a big lag. And when are we expecting more recent than 2021, which is obviously already 4.5 years ago now? And how are we augmenting that with like the community survey, or what's the timeline for the next one, and how are we dealing with it in the meantime?
So yes, we do have unfortunate data lags, and they will always be on a 2 to 3 year lag to get this type of in-depth data. We also look at things like essence data, which comes from emergency rooms and outpatient visits, where we're able to pull things more quickly. Maryland Department of Health has a new dashboard. They are in the process of developing a health equity dashboard, which will also be a little bit more up to date. But we also hear from the community. So our community health needs assessment, which was a series of focus groups and community conversations, also brings in some more kind of up-to-date data and things that may not be shown, you may not see in the big numbers. It's really important to have that kind of local community impact as well.
So you said 2 to 3. I mean, we're at 4.5 with this. Just so, is there one imminently coming? I'm just trying to understand the rhythm of it, because this chart, or did you just choose to stop it at 2021? Because this one says health equity in Montgomery County 2013 to 2021. There was a decision made.
So the data comes out. So the data for 2021 comes out in 2023 and then takes a year to analyze. So this report was actually just released last year.
Year to analyze that. So it's going to be what we actually see is going to be more like a 4-year. This is what it will be.
This is
like.
the most recent report.
Got it. And the last thing I just wanted to ask, and then just plug, I said this last time you were before us when we were talking about the deaths in the context of the opioids, and I pointed out that all of them were men. And we had an exchange, if you remember, about this, and I think that might have been last year. I think it was last year. I don't know if that's still the case, and you can answer that too, but in the deaths that we are seeing, but we're also now seeing a increase, it was talked about by Councilmember Fanny Gonzalez, in the intoxication with Hispanic men. There's actually in the last year, there's been a lot more out in the world in general, just about are men okay? Big Atlantic article a couple months ago. While suicide and all that have always been higher, I'm wondering, I think we're reaching a critical mass, and like now the number one predictor of college dropout is are you a guy? Like that's the number one factor. It's surpassed every other factor. While wages for women have gone up and not enough, but the reason the gap has shrunk is because wages for men haven't gone up. And so I just wanted, I'm worried about this in our context of the larger context, isolation, the online stuff. What are we doing and what are we seeing in the data to try to get ahead of this in our context?
Thank you for that question. If anybody has not read of Boys and Men by Richard Reeves, I highly recommend it. It is a look at this exact issue, and I will say as a mom of 2 little boys, something I care about deeply, because if we saw these disparities in any other group, it would be on a slide, and it would be a huge crisis. And our men and boys are a critical part of our community, and we need to make sure that they are getting the necessary attention and access that they need. Dr. Bridgers and I have actually had many conversations about what can we do as a department to address these exact issues. So we did have, we started some conversations with the Greater Washington Urban League about their fatherhood initiative and how do we potentially expand that to Montgomery County. Within our state of Black Health listening sessions that we're going to be rolling out. We will be asking specific questions about how do we support our male constituents, both men and our young boys. I know our positive youth development teams and CYF and Luis has been doing a lot to really focus and emphasize on the mental health of our young men and boys as well. So I just want to say I think your point is well taken, and we have been having conversations about how can we not just raise awareness, but actually develop meaningful programs, because the data also shows that when you develop a job readiness program for college women and college men, the college men still don't do as well as the college women. And so I think men and boys have very unique needs. That doesn't mean we don't think about the needs of women or we diminish the women. We can have men be successful and close that gap, but while also supporting women empowerment. One is not at the expense of the other, and it is off balance right now. And I think we have a great opportunity across the entire department to figure out how do we close that gap. So not a specific program that I can tell you, but just want you to know that I hear you, and it is something that Dr. Bridgers and I have had many conversations about.
Well, and I appreciate that, and want to work with you on this, as I'm sure all my colleagues do. We're often the tip of the spear, figuring out tough ways to deal with tough challenges, and I think this is one that will benefit everybody, and appreciate that you're looking into it. Thank you, Madam President.
Thank you. Next, we have Councilmember Katz.
Thank you, Madam President, and thank you, Dr. Davis and Dr. Ashford and Mr. O'Donnell. I have to tell you, and Mr. Stevenson as well, I have to tell everybody that I always say that Montgomery County is such a big place that we have 2 Ben Stevensons that work for Montgomery County. That's how large we are. I want to publicly thank Councilmember Albornoz and his office and all of you for working on this Kratom issue. I had never heard of Kratom. And a friend of mine who's a physician contacted me because he had another friend whose son had all sorts of issues associated with it. And so, you start looking into this and you figure Alabama and Arkansas or ahead of Maryland or ahead of Montgomery County, Maryland. How's that working? And it's a huge problem. The District of Columbia, I guess, is also banned it. But since I became aware of it, I've seen neon signs for it in a vaping shop and a cigar shop that had Kratom on it. And I thought, what in the world are we doing? This is, and you're right, the marketing is for, it's for young people. It's to hook them in many ways. But I guess beyond everything else that we're doing, and we do need to figure out what's the next step here, since it just came into effect in the state of Maryland in October, so we don't have it, to Councilmember Jawando's here, it's taken 3 years to get any background. We can't wait 3 years on this. So since it just came into effect, how are we going to track it? To Councilmember Balcom's point, how are we going to track it? Are we going to do it separate like we do for fentanyl? How is that going to work? And what's our next steps?
That's tricky. We don't really have a way to track it. And I think that is part of the challenge. Because it's not regulated in any way, there is not really a reporting mechanism to know which facilities, which stores have it, other than going to the facility and surveying the ones that we have. And so I think that's part of the challenge as we ourselves are trying to better understand how extensive Kratom is in the county. I think to Dr. Ashford's enforcement point earlier, I think another challenge that we have in being able to fund enforcement, tobacco comes with taxes that fund enforcement. Cannabis comes with taxes that fund enforcement. Kratom, because it's not regulated, there are no taxes on it, it doesn't come with any additional funding to be able to do that. So that might also be an opportunity to be able to then use those funds to better track and enforce where it's being used.
Thank you. As I say, I know we have an issue. It's not as big at this moment but if we're not careful, it will be. It could be another fentanyl. So thank you very much for all that you do. Thank you, Madam Chair.
Councilmember Mink?
Thank you. I echo all the thanks and appreciation during these tough times. Very glad to be here in Montgomery County with a team like who we have before us today. So thank you all very much. I'm going to go back to the mobile health clinic slide 4, I think, where it says the East County Service Consolidation Hub is to be established. I wonder if you could talk a little bit about that.
So I believe that is now been finalized as Kingdom Fellowship, and we'll be partnering with them on sites for that.
Okay, just wanted to make sure that I wasn't missing something there. Okay, great. We appreciate you, Kingdom Fellowship. Thank you. We were wondering also on slide 8, we as Councilmember Lukian, sorry. Yes, on slide 8, there's a reference to drug poisoning in regards to the older age group, and then there's also overdoses. What is the difference between poisoning and overdose?
It's not much. It's when they pull it from the ER data, that gets both. So if you just look at poisoning and not overdose, they mean the same thing, essentially. It's just a way of pulling the codes.
Okay, thank you. On the response to the increase in DUIs in Hispanic males, you mentioned that part of the work is working with MCPD on alternatives to incarceration. Could you say a little bit more about that work?
So the idea is similar to what Councilmember Fanny Gonzalez mentioned. So about like safe rides. So trying to get people alternative safe rides home versus them actually getting behind the vehicle of a car, or even trying to also just provide additional education and resources to the community, just to try to prevent some of the consequences that come with intoxication or driving under the influence.
Okay, and so MCPD's role in that are they helping with the education and outreach part of that, or?
It would be a little. I believe it's a little bit of both. I can confirm and circle back with you, but I know that they are supporting education modestly, but also just trying to figure out innovative ways to try to keep people from driving and things like that. So I know there's been conversations around like safe ride alternatives and actually providing that type of information to people when they come in contact with them.
Got it. Okay. All right. Thank you. On the respiratory diseases, just wanted to note again, glad to see, of course, that hospitalizations continue to be down for COVID. Unfortunate that they're up for other areas. I'm sure we're going to continue to see those various fluctuations. But also, I think, once again, that it's really important that we're clear to folks that while the COVID risk at this point is not primarily hospitalizations and imminent death, and that has for a while now luckily not kind of been the primary concern, there continues to be increasing evidence about the long-term implications. And so I just want to make sure that when we have these presentations that we are balancing that information, because people should not take that as I'm much less likely now that I'm getting my vaccinations and so on and so forth, to be hospitalized because of this, with that, that this is not important anymore, so maybe I can slow down on some of those mitigations. Those are part of what help to keep us safe. And so people understanding the risks, framing the conversation, making sure that we're framing the conversation as, again, the risks are not so much this, but they are that, and we're seeing that impact on the cardiac side and various other spaces that are longer term, is really important. If we could please make sure that we're including that. Great to hear, although depressing to hear, as Chair Albornoz noted, the considerations about what we're going to do with, I'm just going to say, when we get the non-science-based recommendations from the federal level. But it is good to have confirmed here for the public that yes, here in Maryland, in Montgomery County, that is something that we are thinking about and accounting for. They have been clear at the federal level that science does not come first, and so we are going to need to hunker down here in some way, and that's going to be a major public information challenge. But I just want to express my gratitude that here we are, in fact, looking at this, clear-eyed and putting pieces in place to be able to mitigate that. And with that, I will yield.
Okay. Councilmember Lass.
Thank you, Madam President. I appreciate the conversation and the deep dive into the health of our community. I want to go back to something I think that might have gotten lost in the middle of the presentation, highly important, and it was about all of the programs that we provide, which is what a lot of the questions are based upon, and the programs we provide being based upon Medicaid reimbursement. And I know it was noted before, the number of individuals who receive benefits, who get health care. Can you elevate that, lift that back up again? Because there's a lot that we have to prepare for. And I think people have to understand how much of our local health care is based upon that.
I can talk through this slide just a little bit more. So this was slide 32. There are two numbers that are projected. The non-MAGI, which is the non-income based Medicaid. So when we think about Medicaid, we think about those who are disabled, which represents about 27,000 folks. And then on the right-hand side, the total enrollment, and also which is about 179,000 people, 19 to 20-year-olds who are living with a parent, about 3,000. But I want to draw your attention to expansion adults, which is 46,000 people. Those are people who gained insurance through the Affordable Care Act between the ages of 19 and 64. And that is a very significant population. That is that is the population that is in many ways being attacked by the HR1. What HR1 has proposed is that, they will still fund children and pregnant women, but will change coverage for expansion adults. And so that is a significant amount of people that would potentially be impacted right here in Montgomery County.
Thank you for going through that. So the three numbers that I heard you reference, 27,000, 46,000, and 179,000. If I heard you correctly, it's a concern that there are 46,000 Montgomery County residents who are at risk of maintaining their health care should Congress move forward with President Trump's bill. So those are funds, just to understand even at a deeper level how that works. Those are funds that we get and are reimbursed for either from the federal government, or is it from the state as the pass-through?
So a little bit of both. There is federal matching, so part of those funds are from the state. So the state puts in money and the federal government puts in money, and they are matched at a kind of 90-10 percentage.
And the organizations that we provide support for, right? Because the Medicaid match is supplemented by county and state, right? For the organizations that are doing that work.
So the organizations that do that work would be the broader healthcare system and infrastructure. So the county, I'm trying to think of the right wording here. I wouldn't necessarily use the wording supplement.
Sure.
I think there are—
It's a very technical term in this respect.
Yes, in this respect. There are individuals who qualify for Medicaid that might qualify for other county programs like SNAP or WIC or housing. When we're talking about it purely in the context of healthcare, typically if our healthcare programs, so Montgomery Cares, Care for Kids, if you qualify for that, you don't qualify for Medicaid. So really the biggest impact would be if those 46,000 lose their Medicaid coverage, they would now be eligible for Montgomery Cares and Care for Kids, and we don't have the funding to be able to support that. I think the other, just thinking about the other place that this touches, Medicaid is a requirement for our maternal and child health programs. So all of those individuals, and that would be the 1,704 Healthy Babies Equity Act women, and then the 3,100 pregnant women. So it's a much smaller sample than that 46,000. Those folks are likely not at risk of losing their Medicaid with HR1, so there would not be much change to them accessing our maternal and child health services.
So thank you. You articulated it well. It's the 46,000 residents who currently get health care through Medicaid who, should they no longer, they would fall onto the county to try and provide support for, and that is a funding issue that the county would have to supplement. Going back to that word supplement, right. Where are you all thinking in terms of the landscape that we have? What is the capacity, if there is any capacity, to expand with the resources we currently have?
I mean, the Montgomery Cares clinics have said that they have some additional capacity. I don't think some is 46,000.
Sure.
And having additional capacity also doesn't mean that we have the budget available within the program to actually support that. I think the other thing that you just have to think about in context of the broader safety net is that those individuals lose their Medicaid coverage. That's a revenue stream that the clinics are losing as well, because all of our Montgomery Cares clinics have to accept Medicaid. And so we need to think about their bottom line and their financials of if they potentially lose this large population of folks because they lose their Medicaid, and if they will be able to remain solvent if they lose their Medicaid book of business.
That was the other use of the term supplement, right? Because the nonprofit businesses have various revenue streams. Some of it's from the county and state, and others is from the Medicaid. That's right. Add this to the other looming issues, particularly the $113 million that we received from Title I and what that means for schools. Add that to all of the other areas where we're dependent on some sort of funding from the federal government, and it is alarming and concerning. I appreciate you all thinking ahead, not necessarily having the answers, because it's largely a budgetary issue on how we supplement the loss that will happen. I agree with the sentiment that we may need more conversation depending on what happens, and clearly the General Assembly is already put on notice should there be major Medicaid changes. They're on notice to come back to figure out how the state budget and the state healthcare network is able to accommodate. So this is an evolving target, but I'm glad that we have this team in place and all of you making sure that our residents are healthy and safe, and appreciate the conversation.
Thank you. Councilmember Lukey.
Thank you, Madam President. And I know we've had several folks interested in the ABS and other alcohol prevention piece here, and that's something critically important to me. And I wanted to highlight that we have several phases of this, right? We have the public health side. We have we're going to step up enforcement at times where we know more DUI-related behaviors are occurring, because if we're announcing that and publicizing that, the hope is that you're deterring the behavior from happening. Those enhanced enforcements, and we have one ongoing right now, this is new this year between Memorial Day and Independence Day, also yields that information about those businesses that are over-serving. Because there are patterns that they're able to discern from that. And there is a bit of a hiccup there with how ABS is or isn't handling things. And there's only so much that's within your authority or within the police department's authority. And the third piece of that puzzle is, in fact, ABS and these businesses. And so that's something critical that we all need to be attuned to and make sure is being dealt with great fidelity. The police department does do underage alcohol by enforcement. I don't know how frequently, but I do know that they do it. And I know that Officer Derbyshire, who runs our Green Labs program within the department, is the one who kind of oversees that. And I think it's also important to remember that impairment doesn't mean illegal. And so to the point of everyone's questions about Kratom and other things, a perfectly legal substance can impair your driving too much Benadryl can impair your driving, right? So it doesn't have to be alcohol, which is legal, cannabis, which is legal, or an opioid, which is not legal. Or maybe if it's a prescription. Again, it depends. But those things are all really, really critical pieces of this puzzle. And I just also wanted to lift up, we do have diversion court programs for the, if you've already gotten the DUI, if you've already had an encounter that has yielded some kind of conduct that's going to put you in the criminal justice system. So we have a DUI court, and they just had their first cohort graduate from DUI court. It was a great day. And we have a drug court and a mental health court. So, and the programs are really good and really passionate people. And I know you all work collaboratively with them on this, and the outcomes are very positive. So I thank you all for your cross collaboration there across different branches of government. With respect to the alcohol-related deaths that you discussed early on in your presentation, how many of those, or what percentage estimate, are related solely to the alcohol consumption versus the alcohol consumption contributing to a behavior such as the driving or some other accidental conduct that was because of the effects of the impairment, meaning cardiac related or some other, or respiratory related from the depressant effect of the alcohol versus that other type of accident?
I don't have those numbers. We can look in to see how much of those are because of fatality, like car accident fatalities versus otherwise, but I don't have those numbers offhand. And
then for the crisis stabilization room and the figures you had for 2024 on that, you noted that 70% had substance use disorder who utilized the crisis stabilization room. Do you know how many of those who used the crisis stabilization room had a coexisting behavioral health condition?
I don't have that number. I'll make sure we can get that number to you, though.
Thank you. And on the maternal fetal care piece, and thank you for circling back to how we did vaccinations during COVID and how we used our more indirect methods of reaching people. My big worry about this is any gains that we have made that have been positive based on these types of programs we do have are going to be lost at this time because women are not going to seek care until very, very late in their gestational period and may have significant consequences for either themselves or the babies as a result. And so specifically with respect to maternal fetal health, because I know you addressed it in the vaccine context, but what are you doing to help with that kind of outreach in those less direct government to individual ways to help bridge that gap?
Yes, that is a great question. I will say that I don't believe we've seen a decline in moms and babies receiving services. I will also note that our team has we worked collaboratively on, just got a grant with Robert Wood Johnson Foundation. The county is not the primary, but Latinos Unidos of Maryland is, and working with Holy Cross. So it's a multi-sector partnership to actually use their CHW program, Community Health Worker Program, to go out into the community and engage with our clients, and try to do education about why early entry into prenatal care is important. And so we're really, as Dr. Davis mentioned, trying to leverage outside grant sources to help fund some of this additional education and outreach work to be able to do that. Also through our community advisory teams and FEMR CATS and the Maternal Health Convening Summit, hopefully the establishment of the steering committee that there's some grants that are going to be submitted for that as well. We'll continue to be able to do more of that on the ground work to continue to not just advertise our services, but get people into early prenatal care.
Great.
I'll just add on, I think Maryland continues to be a bright spot in terms of reproductive health and reproductive health justice. Governor Moore is committed to the state being a place of training. So as many training programs around the country have shut down, they are looking at funding to help make sure that that physicians are trained in all aspects of reproductive health. And so ensuring that knowledge isn't lost. And so I think that also the state has continued to fund that investment and be proud about supporting women in all facets of their reproductive health journey.
Great. Thank you so much.
Okay, Councilmember Friedson.
Yeah, thank you so much. I think I'm next to last on the list. A lot of my questions have been asked. I just, first of all, want to express my appreciation, as many have echoed. Public health is under assault. It is a challenging environment. Our vulnerable communities in particular are at higher risk than they have been before because the social safety net is being intentionally decimated. So thank you for all the work that you're doing. Thank you for your commitment to this service for our community. And thank you to your whole team, since I know you're here, but you're really representing a significant team that's behind you. And I know all of us express our deep appreciation for that. We need you now more than ever. Unfortunately, the holes have gotten bigger at the other areas of where the safety net was. And so now we're going to have to catch as many of those who fall through those cracks as possible to make sure that we're lifting up and supporting our community. So thank you. Clearly there are like 9 different dynamics, 10 different dynamics here that you're battling all at once. It is a multifaceted dynamic, so that is a challenge. I did want to speak to, in light of that, how are we dealing with these emerging things that happen that we're not totally prepared for, like 111-degree heat index dynamics. We already had our first death, unfortunately, from my understanding, even before this heat wave, which was a child, a young woman who died. And last year, I think we had the most in the state of Maryland since 2018 heat-related deaths, 26 statewide. How are we responding? How are we helping? How are we supporting? Particularly I'm thinking about unsheltered residents, and I'm thinking about children and our older adults, each of whom I think are particularly vulnerable when we have heat indexes at this point. How do we approach that? Do we have teams to respond to that? And the first is the specific, we're in this moment now, what are we doing? How are we responding? How are we coordinating with other state and regional partners? And our other, county departments and agencies. And number 2, just in general, how do you respond to the emerging temporary threat like this? I think which is different than how you approach a new virus that comes down the pike, or an epidemic, or other dynamic that has an all hands on deck approach. Particularly in light of the fact that we don't have a lot of guidance nor support from federal public health entities like we used to.
Well, I'll start, but then I'll also turn it over to our former emergency manager, who also did a lot of this. I mean, I think a lot of it does speak to the team. There is a lot of coordination and collaboration that happens behind the scenes from the Office of Emergency Management and Homeland Security, HHS, the police, the homelessness, especially in response to this, latest heat wave, that are all coordinating. We started on calls last week when we saw that the heat was coming, of how are we preparing, how are we thinking about cooling places and sheltering. And so I think who's running point on the communications, so all of that work is happening behind the scenes. Hopefully it looks seamless to everybody else, but I think like ducks on the water, there's a lot of paddling underneath that you don't see. And I think it does speak to the level of coordination that happens across the county. But Sean, who kind of went through COVID with us and helped as we, I think can respond to how we as a county address, emerging threats as they come out.
Yeah, this is a good point because we're in the middle of a heat wave. We do have an interagency call. We have a county-wide plan. And we work with our state partners on these things. It's very challenging. our partners and stuff, you're correct. They have a big role in making sure that our unhoused populations, that word is going out to them. When you have extreme temperatures, they expand their hours, that individuals are allowed to be in the shelters all day. They don't want people leaving during these heat emergencies. We work closely with our aging and disability partners to make sure that those sensitive populations are aware of the risks. Those are, you know, we had a discussion yesterday with our mass care team leader about whether or not we would be pushing to open facilities overnight if these heat waves continue. And one of the concerns is obviously populations who don't have air conditioning in their homes and are at risk, our seniors, are those with underlying conditions, and children who can't weather changes in temperature, extreme temperature, as well as other people. But the concern is, how would you get those populations, convince them to go and stay in emergency shelter in that situation? Fortunately, the temperatures are generally cooler in the night. This is an even bigger problem when you have extreme cold. And the things that we do in expanded hours of recreation centers and libraries and other places, those don't typically go overnight. And that's when it's the coldest. So that's an even more challenging situation. I do have a fear that we're going to have people who we don't connect with, don't hear the message about how the temperatures, and don't have air conditioning. But we do rely on a lot of our partners who work with those communities to make sure that they're safe. We work very closely in public health with our long-term care facilities, and we reach out to them and say, if you have any concern about your power situation, you need to notify us immediately so that we can work on these. We've seen tragedies in other states where it's happened, and we're concerned about that. So it is a lot of partnering with our other community partners, both within HHS, within other organizations, as Dr. Davis mentioned. It seems like this will become more of a frequent occurrence with the rising temperatures. And again, the people who are disproportionately impacted are those without the resources to have AC and to have alternative places to go. So.
Appreciate it. Well, keep up the good work. I know this is a challenging moment, a challenging week, and just really appreciate it is a source of pride for all of us, despite the challenges, that we are home to the preeminent public health institutions on the planet. And I think we are home to the best local public health department. So thank you for all the work.
Councilmember Sales?
All right. Thank you, Madam Chair. And thank you to our panel, Dr. Davis, Dr. Ashford, Mr. Stevenson, Mr. O'Donnell, for the incredible updates of all the work that you are doing across the county, speaking at, supporting, organizing events and initiatives to serve our community. You are on the front lines of public health, and the strategies that you are identifying to address these issues are so important, and just appreciate your leadership. So I'm going to start from the top with the mobile health clinic. I am so excited as well that it's finally here. I just wanted to see if you could briefly share the criteria that you use to guide the frequency of our mobile health clinics, how they're deployed, and how you prioritize health events at the key locations across the county. I saw that there's a difference in how often they're making their way across the county, and then how we determine if, how are we going to evaluate the effectiveness of these mobile health clinics and health fairs?
Sure. So the sites were chosen. We tried to go where people are. So the point of the van is to go where people are and not have them come to us, right? And so that's why they are in conjunction with our food consolidation hubs, because that is already a trusted place. People are already coming there for services. And so we are building upon that model. In terms of the health fair event requests, those are prioritized based on zip code. And so we have our primary care, our healthcare shortage areas, our equity areas, and so those are prioritized in health fairs. I will put this out now. The health fair will not, the mobile health van will not solve every need in the county. It cannot be at every health fair. The team is out 3 days a week, Tuesday, Wednesday, Thursday. And then their Mondays and Fridays are their administrative days to follow up with people. Maybe they saw somebody who had high blood pressure or high blood sugar, and they're doing those calls and outreach to make sure that they are following up with folks. But they work a full 5-day week, which then limits their availability to be able to go out on weekends and evenings for additional health fairs and clinics. It's a small team. So there is some cross-training that is happening to be able to extend services, but and we will get to some health fairs, but we probably will not get to all of them in the first year. Those are prioritized, again, based on zip code and where we know that there are shortage areas. We are really trying to go to communities where we have seen disparities and identified a need. We are in Poolesville a little bit more, so we're in Poolesville 3 times a month because of the lack of healthcare access there. We know that there's only one primary care clinic in Poolesville, and they don't take Medicaid, and so there's very limited resources available for that community.
Thank you for that. Also wanted to ask about the evaluation. How are we evaluating outcomes for these health clinics?
So currently for the van, we are certainly collecting demographic data. We are collecting, looking at what people are coming in for. We are looking at return visits. We are looking at also monitoring on connections to care. So again, I mentioned the goal is, one, we want to see people coming in. So we want to see who is coming, but also the ultimate goal is that are we connecting folks up to care, and are we seeing improvements in health outcomes? So making sure that we are also tracking, they came to us, how many times did they come? Did they go? Did they follow up with that clinic? So looking at the, not just the widget counting of who walked through the door, but the longer term, are they connecting up, and are we seeing improvements in the health outcomes?
And so residents can just go online, Google mobile health clinic to find out where they're going to be any 5 days of the week. How can we ask? How can
I believe the
residents-
schedule is online. Folks can see.
Okay.
Yeah.
Okay. And then regarding the substance abuse, in light of the ongoing overdose crises, Mr. Stevenson, how is the county coordinating its prevention and harm reduction programs with MCPS, especially now that school's out, and other educational institutions? Are there any specific demographics or areas we're targeting to do outreach and interventions?
I know during the summer I've been working with my team to do some outreach at utilizing libraries and stuff like that. So we've had some conversations with library entities throughout the county, not only just for like providing them with like overdose education, but also being able to set up resource tables. So we're actually scheduled to set up our first resource table location this Thursday at one of the, I believe it's Rockville Library. And the plan is to continue to do that throughout the summer to try to not only engage with just the general community, but also young people that access the libraries. In addition to working with a couple of different camps and things like that to still provide education to young people during the summer months. And then also we've partnered with MCPS to provide substance use education, but also just overdose educations during the health classes during the summer, which are virtual spaces. So still being able to do it in a virtual space because we have the ability to mail Narcan kits to anyone in the county as well.
And we still have Narcan at our fire departments across the county?
Yes, we do.
Okay.
We actually just gave them a few hundred about a week ago. So yes, we do. Yep.
Okay, I just wanted to make sure that we weren't just doing it at libraries, but we're taking advantage of all of the recreation centers, the playground, summer camps, to ensure we're reaching all of our students, all of our young people.
Just to kind of piggyback off of that, I know we already have about 12 to 15 events we're participating in this summer.
Okay.
So all of those events will always have Narcan at those events, and fentanyl test strips and xylazine test strips and pretty much anything under the sun for just in case somebody needs it. And then we also have the ability to deliver to anybody that might need it if they're not able to get to our office.
Is there a shareable flyer or a landing page for all those events regarding this?
Well, I know we're not necessarily the ones that are leading all of the events. I know I have all the Summer of Peace flyer information,
Yeah.
which you might have seen.
Definitely.
But then there's a few other events that I could definitely share that information.
Yes, if you can, please.
And Councilmember Sales, I would just add to that, there is Narcan in all of the school health rooms within all of the elementary, middle, and high schools across the county. And actually, over 300 of our school health nurses and techs were trained on youth mental health first aid a few months ago as well, to be able to spot warning signs and symptoms.
So, okay. But during the summer, they're not accessible.
Correct. During the summer, that wouldn't be
Okay.
accessible unless they are in an extended school year.
Okay, thank you. With regards to the overall health of the county, can you remind me how many individuals were hospitalized for the influenza or RSV, and whether or not they were vaccinated or not?
So I can tell you that I don't have the numbers in front of me on the RSV influenza vaccination rates by age. We do look at where we get numbers from the state on flu vaccinations, and we are currently working to pull numbers on the COVID vaccinations because we're right around the end of the year for that season, right, and to go into a new season. We've looked at the numbers. They're significantly lower than they were during the COVID years, and we will be looking at the disparities between our populations. We know that our pediatric age folks have the lowest vaccination rates for these. I will be interested if we can get the RSV numbers to share that, because that's a relatively new vaccine that's out there, and I'll be interested how those are going out and how how the uptake is. So,
Yeah, and then with regards to who's been hospitalized and who's unvaccinated, if I could get that information, because we may need to increase awareness about vaccination clinics, especially when school resumes after the summer.
The hospitalizations for younger folks, even though they tend to be very, very low for those, with the exception of our 1 year old and under, which again, they're for many of these, they aren't eligible to be vaccinated until they hit 6 months or they hit a year. So that may be part of the reason, but it's also, there's just an abundance of caution with those populations because they can't tell you what's wrong, and so the parents often will go just to make sure that it's not something else. So that's why we see those ER visits really very high for that population.
Yeah, I just know that with the new leadership at the Health and Human Services at the federal level, it's important that we are providing residents with the most up-to-date and accurate information and ensuring accessibility for our residents so they know the importance of getting vaccinated and also the impacts of not getting vaccinated. I know that we've always seen lower rates of vaccination, especially being a diverse community, but are we seeing any new approaches to building trust in our diverse communities to encourage residents to seek treatment, especially among our communities of color?
I will mention, and then I'll turn it over to Dr. Davis, but I will mention that our immunizations team, and that includes a program that resides at Dennis Avenue, but it also includes our school health team and our maternal and child health team. They all give shots. They are very proactive in trying to find ways to convince parents. You, of course, have your school required vaccinations, and then you have other vaccinations that may not be required by the state to attend school, and they're referring to those as life-required vaccinations. If you want to stay healthy, you want to keep living, these are things that you should have, and it really helps. There's a way to communicate with parents about getting their child vaccinated, and not saying these are optional vaccinations, but framing them in a way that they understand these are really important for you to have. Many many folks will wait until they hear from their doctor that they need to get this vaccination. And we know so many of our residents do not see a doctor on a regular basis. So within public health, we take that very seriously and trying to encourage them to get all the vaccinations that are recommended.
Thank you. Do you have something?
I'll also add, we've been working with our African American Health Program, Asian American Health Initiative, and Latino Health Initiative on a specific vaccination campaign. There was funding associated with that. That funding went away, but they had already started working on what those campaigns are. And so I think they'll still be able to implement some of that for the fall on a possibly on a more scaled down basis. But we are excited about the work that they've been doing to help to reach communities.
Good. And anything that we can also push out as well, please share. And then lastly, my favorite topic, maternal health. I commissioned a report when I was first elected on Black maternal health after I saw a post in the Washington Post about this issue and the national dilemma about this issue. But being such a wealthy county, I was saddened to see that we have issues right here at home that we can certainly address. And I was at the Juneteenth event of Scotland Heritage Festival and happened to be talking with someone who reminded me about the birthing center that we had here in the county, because she actually gave birth to her first child there and then had to go to the hospital for her second child because it was closed, and the complications that she experienced, the discomfort and the fear. And so I know that since 2013 that birthing center has been closed. I don't know what the impetus behind that was, but I do know that we have, I don't know how many of our hospitals do births, but just wanted to better understand. The report includes recommendations that we need to reopen a birthing center here in Montgomery County. So I'm glad that there's a steering committee who will hopefully verify and champion this effort to ensure life-saving environments for our Black mothers and babies. So just wanted to see if you can share a bit more about any other recommendations you anticipate this committee championing or recommending, in addition to the programs that they reviewed and evaluated and showed that some of our programs are outperforming others, and if there's a interest in possibly putting more funding to those than we have in previous years.
I'll start, and then I'll hand it over to Dr. Ashford to talk about some of the kind of programming and restructure that could happen. I don't want to get ahead of the steering committee. I definitely think, a birthing center in Montgomery County is something that committee will look at. We know that birthing centers tend to have better outcomes in terms of C-sections, fewer C-sections, and women really love it. I can't speak to why the birthing centers in Montgomery County closed or across the state. I don't think we have any left in the state of Maryland anymore. But from the folks who delivered there, I know folks who used to work there, they really reported a positive experience.
The feedback, there was actually a woman she was a midwife at the birthing center at the Maternal Health Summit, and the reimbursement structure didn't support the financial operation, so it had to close. And that's a consistent issue with birthing centers across the country, and sometimes it's driven by regulatory restraints and requirements from state or local that put onerous requirements, like you have to have an ER bay, which is not necessary, right, for a birthing center, or even licensure requirements among the midwives, who typically are the providers that deliver their yes, exactly. So it was they just weren't financially able to survive. But I think we all agree. We would love to have a birthing center back in Montgomery County, especially because we know, particularly for our Black and Brown moms and birthing folks, that birthing centers are a very evidence-based proven strategy to improve outcomes. As far as our programs, to that question, we have been all over this data for the past, I think, 3 or 4 months since we got our hands on it. And so we have been looking internally. We've actually had 2 internal maternal and child health strategy sessions just among our MCH teams to look at potentially restructuring and realigning resources within those programs so that they better mirror the disparities. That's not to take care away from any group, but to make sure that when we look at the disparities, we're actually aligning those resources. We have also been working to really try to continue to strengthen and build our partnership with SMILE, which is run by the African American Health Program, and to leverage lessons learned there. I've asked the team, I have asked the team to do a side-by-side comparison. I was like, I can find you an intern, I promise, if you need to, but of our curriculum that we use in MPP versus Babies Born Healthy versus the new MEHOW evidence-based model that we're going to be implementing with the McV funding that we just got. And where are there similarities? Where are there differences? Does our current approach work? So right now we have community health workers that work with kind of lower acuity moms. We have nurses that work with our more complex moms. Does that structure still make sense from when it was implemented 30 months ago or 30 years ago? Or do we do a dyad model where the CHW and the nurse work closely together? So I have asked the team to basically pick apart the entire program from the systems that we use. I have sat with the ACCU team from the time they get a Medicaid list and said, walk me through your spreadsheet. I want to see which are the systems you have to go to. What are the barriers? How does this system talk to that system so that we don't have 5 different people calling the same patient 36 times? And really looking at where are those efficiencies? What is working? What is not working? What is working for our moms, have gone along on the home visits as well to get to hold the very sweet little babies, which is a added benefit of the job. But we are looking very closely at that to really make some changes and asking the team to lead those changes. They are the experts in the programs. As I told them yesterday, we just had a meeting yesterday. You guys are the ones that do this every day. If you had a free-for-all and the sky was the limit, how would you do this differently and better? And let's not just do it because this is the way that we've always done it. So to your point, yes, we are looking at that exact question. I'm really excited about it. I think it is an opportunity to continue to strengthen the services that we provide to our moms and babies.
Thank you. I'm also looking forward to the steering committee, raising awareness about opportunities to serve and the recommendations that will be forthcoming. I did see that we had approximately 3,000 children enrolled in the Care for Kids program in 2014, and the number has tripled to 11,000. And just wanted to see if you had any insight into those numbers, and is that because we are improving signups or capturing people better?
I think it's sorry, I didn't mean to cut you off. I think it's a combination of things. I think it's increased enrollment in the program. Also, when Montgomery County, as many of you know, we were one of the largest recipients of when they were busing immigrants to newcomers and northern states.
Okay.
Yes, unaccompanied minors, if everybody remembers that period. We received a lot of those kiddos, and so they qualified for Care for Kids program. We also had the program that I highlighted at PCC, where they had some community health workers that were embedded within Rocking Horse, so with the newcomer program, and at the International Welcome Center, they were able to do a little bit more hands-on screening. Unfortunately, that program didn't have funding to continue, but that also helped with increasing the enrollment in that program as well.
Okay, thank you. And then my last question was about our emergency rooms. You know, we have some of the worst emergency room wait times. I just got an email from a resident who spent over 5 hours in the emergency room. I won't name which hospital it was. I know that there's a steering committee at the state looking at this issue. Do we have anyone from the county that's serving on that commission, and any updates about the progress they're making?
I don't believe that we have anybody from the county who is on that commission. I do know that wait times are bad across the state. I think Montgomery County does a little bit better than some of our partners because of the investments in healthcare access. When you're looking at the factors that contribute to emergency room wait times, I really think about it in three buckets. So there's the input. So are people going to the emergency room for the right reasons? Do they have access to primary care to be able to avoid going to the emergency room? They don't have that access either because they lack insurance or there aren't enough healthcare professionals in the community. So then, they end up in the emergency room. Then you look at emergency room staffing. Are our emergency rooms adequately staffed? Do they have enough nurses and doctors to be able to see the volume of people that they need? And then you look at hospital throughput. So are people moving from the emergency room either to be admitted to the hospital or out? And we know that there are bottlenecks along all of those. And so if the hospital staffing is not sufficient in the hospital to be able to take those folks up to the floor to support them in the ICU, then that becomes a bottleneck. But also when we think about discharge to diversion facilities, mental health facilities, where folks may need to go, those folks also end up being in the emergency room for long periods of time. So I know that there is work on all of those in all of those areas. But not as connected to what the state recommendations are right now.
All right. Thank you all, and looking forward to continued discussions. Thank you.
Councilmember Mink.
Just wanted to note the Rocking Horse closure, that it would be great to follow up maybe in a joint committee session to make sure that we really understand the implications of that and what else we might need to be doing on that front, and just to hear more from you all about what you're seeing related. Great, thanks.
Great. Thank you so much. You've been here for over 2 hours. There's so much more we could talk to you about, and we appreciate the partnership and the collaboration that we have with you. And we know while we have these public, reports that and back and forth, that all of us, particularly our HHS committee, works very closely with all of you and your staff, and we really appreciate that partnership and all of the work. So look forward until we see you all next time. But with that, we are adjourned.